All right, let's step into the clinic. We've taken a deep dive into an expert discussion between two leading contact lens specialists, Laura Batras and Diego Lopez, and we've distilled their insights into a clear, actionable masterclass on examining the ocular surface. Let's get right to it.
So, here's how we're going to break it all down. We'll kick things off with the absolute foundation, the patient history. Then, we'll jump into the essential tools and the key fitting concepts you need to know about today. After that, we'll cover proper management and maintenance. And to finish, we'll wrap it all up by applying these principles to some real-world clinical cases.
Okay, let's dive right into Section 1. Both our experts are totally aligned on this. The patient history, or what we in the biz call the anamnesis, is the absolute bedrock of any successful contact lens practice. It's where the entire clinical encounter begins. And this quote right here, it really gets to the heart of the matter. As Laura Batras puts it, a great consultation isn't about rushing through a checklist. It's about taking the time you need to really understand the person who's sitting in your chair.
So when we talk about the anamnesis, you're really trying to do two things. First, and maybe most importantly, you have to gain the patient's trust. And second, you need to extract that crucial information. Remember, this isn't just a form you fill out at the start. It's a conversation that evolves. As your patient gets more comfortable, you start to uncover those little details that can completely change your fitting strategy.
And you know what this all boils down to? Simple preparedness. If you go into a consultation cold, you're wasting everyone's time, you're asking questions they've already answered, and you're slowly chipping away at their confidence in you. But when you've done your homework, it's a different game. You optimize every minute, your exam is focused, and you build that critical trust. It really is the mark of a true professional.
And check this out. Laura Batras offers this brilliant little framework for evaluating pretty much any clinical process. She says you should always ask yourself 3 questions. Is this making me lose time? Is it making me lose money? And is it damaging my professional category or reputation? If the answer to any of those is yes, that's your sign that the process needs a serious rethink.
Okay, so we've laid the foundation. Now let's talk about the tools of the trade, the stuff that's absolutely non-negotiable for a proper ocular surface exam.
So let's start with the big one, the slit lamp. Is it really a must-have for every visit? Can you maybe skip it on a routine follow-up, especially if the patient comes in saying everything feels great?
The answer from the experts could not be more clear. It is an obligation, not a suggestion, not a nice-to-have. It's mandatory. Every single patient, every single visit, full stop. Because, as we all know, a patient feeling good doesn't always mean the lens fit is good or that the cornea is healthy.
And you know what? The exact same hard and fast rule applies to staining. As specialist Diego Lopez says, if you call yourself a contact lens specialist, you should be using a ton of fluorescein. It's the only way to truly see what's happening on the surface of the cornea. Without it, you're basically flying blind.
Okay, but what about the corneal topographer? Well, its importance really depends on what you're fitting. For Ortho-K, it's mandatory. You just can't do it properly without one. For scleral lenses, it's considered very important to get that optimal fit. And for your standard day-to-day soft lenses, it's highly recommended. It gives you data that can help you head off problems before they even start.
And that actually leads us perfectly into Section 3, where we're going to talk about the key concepts that are really changing the game in contact lens fitting today. We're moving way beyond the old school approach.
And if you want to sum up this new way of thinking in just one sentence, this is it. The art of fitting is no longer just about matching a base curve in diameter. It's about finding the correct sagittal height, or sag, for that particular eye. This measurement of the lens's depth is the true key to a perfect fit.
Now, when we're looking at the tear film, we run into this classic clinical puzzle. You can have a patient with severe symptoms. They're telling you their eyes are dry and uncomfortable, but your objective signs, your BUT, your staining, everything looks totally normal. And that right there is exactly why subjective tools, like the OSDI questionnaire, are just as vital as what you see in the slit lamp.
All right, on to Section 4. A perfect fit is fantastic, but that's only half the job. Long-term success depends completely on proper management and maintenance from the patient.
You know, when we're fitting rigid gas-permeable lenses, it's easy to get hyper-focused on the fit itself and kind of forget about the material. But you have to consider DK for oxygen permeability and the wetting angle for surface hydration. Just switching to a material with better parameters can sometimes be the one thing that turns a failing fit into a raving success.
And speaking of maintenance, this brings us to that age-old question we get from patients all the time. When it comes to cleaning lenses, do I really need to rub them, or is just rinsing them off good enough? While the expert consensus on this is incredibly clear. For monthly and bi-weekly soft lenses, you must always rub them. Same goes for scleral lenses. The only major exception is Ortho-K, where the preference is now a no-rub protocol using a peroxide system. It's just simpler for the patient and provides powerful disinfection.
Okay, for our final section, let's bring this all together. We're going to take everything we've discussed and apply it to a couple of common clinical challenges that I guarantee you are going to see in your practice.
So, clinical challenge number 1. You stain a patient's cornea and you see this, superficial punctate keratitis. It's a common sign of diffuse inflammation on the corneal surface. So what's the game plan?
The protocol here is straightforward, and it is non-negotiable. First, the patient must stop wearing their lenses immediately. Second, that keratitis has to be treated, whether you do it or you refer them out. And third, only after that cornea has completely healed can you even begin to think about refitting that patient.
Here's another common sight, especially with lens abuse: neovascularization. This is where blood vessels start growing into the cornea from chronic oxygen deprivation, and it is a serious, serious red flag.
Managing the non-compliant patient is a critical professional skill. You have to educate them on the long-term risks and explain that this is a direct result of their choices, a poor fit, or the wrong material. And most importantly, you have the professional right, and I'd argue the responsibility, to stop providing services if they refuse to follow your clinical guidance. Remember, sometimes the best thing you can do for a patient is to say no.
And that brings our masterclass to a close. We've seen that success starts with taking the time to build trust, that tools like the slit lamp and fluorescein are non-negotiable, and that modern fitting is all about sagittal height. We've also covered the crucial role of maintenance and our professional duty to manage non-compliance. So the final question is for you to take back to your practice. After reviewing these expert insights, is your clinical protocol truly protecting the long-term health of your patients and the professional integrity of your practice?